If you have a question for Dr. Donna, please do leave it on my page and I will be happy to answer the question for you. Hey, good evening, everyone. Welcome and thank you for joining and keeping your appointment. As you know, you have an appointment with the doctor every Thursday at 6:30 p.m. And so I thank you for joining. If this is your first time joining us and watching, welcome. I'm Dr. Donna White Carey. I am your host, and this is Talking with Dr. Donna. We are here, like I said, every Thursday at 6:30 p.m. And I would love it if at the end of this show, or even you can do it right now, if you are not already a subscriber to my channel, if you hear anything tonight that just gives you a bit of information, some better understanding of something, anything that you value, I would really appreciate it if you went over to my YouTube channel, if you're watching this from Facebook, and hit that subscribe icon and then that bell right next to it so that you know when we go live, which is when, I just said it, every Thursday at 6:30 p.m. So again, thank you for tuning in. Hi, Lisa B, I see you. We are live, and the reason we're live is because this gives you an opportunity to interact with our guests. And we have some fantastic guests tonight who are going to give you some information that you may not get anywhere else. This is your opportunity to ask questions. So say hello, let me know you're there. We will get to questions later on. But before that, I want to let you know why I have a show. And the reason that I have a show is because I want to build what I call generational health. And what I mean by generational health is looking at your generation and the generation below you and the generation above you and focusing in on your health. We focus in particular on 4 pillars. 1, a spiritual health. 2, your emotional and mental health. 3, your physical health. And 4, environmental health. Because I firmly believe that if we pay attention to these 4 pillars of health in every single generation, then we can work together to end the cycle of premature death in the African American community. That's what we're about. That's why we're here. That's why I bring people every week to this channel to talk about how you can end the cycle of premature death. We are serious about that. And so if you want to be a part of the Generational Health Network, all you have to do is tune in every Thursday at 6:30 p.m. Follow me on Facebook or Instagram at MyDrDonna, on Twitter, TW Dr. Donna, and just let me know if there's a show topic that you'd like to hear about, something that you're interested in, you need to know, want more information about. Let me know. Interact with me. And as we go into the end of this show, you'll see we do a food of the month every month, and we're going to share recipes. We do lots of fun things. So our interaction is not just on Thursdays, but it is throughout the week. So thank you. All right, so let's get into our show today. But before we do that, right, I forgot. This is the month of May, and so I always want to pay homage and love to all of you mothers out there. And that is whether or not you are a biological mother, whether you're raising your family member's child, or you're the mother of the community or a mother of the church. We appreciate you and we thank you for being a part of the village, because it takes a village to raise our children. So I want to thank you to all you mothers out there. And of course, I got to give a special love, heavenly love, to my mother, who, yes, her name is Donna. You probably did not know that I was a junior, but I am a junior. My mother's birthday and Mother's Day are this Sunday. So want to give love and honor and respect to my mother, who is really the one who created this in me, this whole thought about I can do anything that I put my mind to, who never doubted me, never wavered in her faith in me and what I could become. And so because of her and her encouragement, instilling in me confidence, I'm able to do what I do today. So thank you, Mom. I love you forever. And I know you're continuing to look down on and to help. You know, you're probably tapping God on the shoulder and like, no, that's not the direction she needs to go in. Let's have her move this way. So thank you, Mom. And again, happy Mother's Day to all you mothers out there who are watching. All right, let's get on to our show. So our show today is about Parkinson's disease. And if you've ever heard about Parkinson's disease, you probably have seen the image of an older white male or even just a white male in general. Well, tonight we really want to talk about Parkinson's disease in the Black and brown community because it happens, because this diagnosis is within our community. When I posted this on Facebook, there were 2 people who said, oh, my brother died from Parkinson's disease. These are Black people. My brother died from Parkinson's disease, or my aunt died from Parkinson's disease. So even though we don't hear about it a lot in our community, it is prevalent. And so tonight's show is really about increasing your knowledge of the disease. What the heck is it? The awareness of the fact that it does impact people in our community. And more important, what should you do to make sure that you are getting the best treatment possible? What can you do to control the disease, to help mitigate the symptoms? And how can you find resources and support in the community if you are diagnosed with the disease? So that's what we are talking about tonight. So without any further ado, I want to bring on our fantastic guests because I want you all to have as much time as possible with them. And so first, we are going to bring on Dr. Indu Subramanian. Let's bring on Dr. Indu. Hi, Dr. Indu. Welcome to the show. I'm going to read your bio, your lovely bio. So Dr. Subramanian, which we're going to call her Dr. Indu tonight, received her medical degree from the University of Toronto, Canada. She completed a neurology residency and a movement disorders fellowship at UCLA. Hey, you all know I'm a Bruin. Currently, Dr. Indu is a clinical professor of neurology at UCLA, and she established the Movement Disorder Clinic at the West Los Angeles Veterans Administration, and she is the director of the Southwest Parkinson's Disease Research, Education, and Clinical Care Center of Excellence in Parkinson's disease. She has a strong interest in integrative medicine with a special interest in yoga and mindfulness. So you know we love that here on our show, all about generational health. That is Dr. Indu. She's board certified in integrative medicine and is passionate about palliative care in Parkinson's disease. So welcome, Dr. Indu, to Talking with Dr. Donna. All you out there, give her a clap and thank her for her time this evening. Hi, Dr. Indu.
Hi, thank you so much for having me. It's just a pleasure.
Thank you. All right, and so our next guest is Deborah Whittle. Let's bring on Deborah. She is a member of an organization. Hey, Deborah. She is a member of an organization called Parkinson's Disease Active, or PD Active. But Ms. Whittle has over 30 years of leadership in transforming communities with an emphasis on affordable housing, health disparities, social justice, and economic development. Another member of the Generational Health Network right here. She has spent many years doing fair distribution of resources in underserved communities in San Francisco. She also worked on a Theory of Change initiative with the Rockefeller Foundation in combination with the California Endowment called California Works for Better Health. And she served as the executive director of Glide Community Housing. In 2016, Deborah was diagnosed with a brain aneurysm, breast cancer, and Parkinson's disease all within 3 months. And this brought to the forefront the issues of health disparities that she's been working on for a great part of her career into on a personal level. So we're going to hear more from Deborah, but let's welcome her to Talking with Dr. Donna. You guys give it a little clap out there. Welcome, Deborah. Thank you both so much for joining us tonight. All right, let's get started. All right, I see lots of folks out there. Remember, if you have questions, type them into the chat so that we can ask our esteemed panelists. So let's start with you, Dr. Indu. Can you tell us what exactly is Parkinson's disease?
So Parkinson's disease is a very common. It is in the category of what we call neurodegenerative diseases that include things like Alzheimer's, dementia, things like that. It has not just motor symptoms that are presentation. It also has a host of motor issues as well as mental health issues that are part and parcel of the disease. About 1% of the population in the United States has Parkinson's. So it's not unusual, 1 in 100 people. It is we see more and more people in our social systems that will get Parkinson's disease. As you mentioned, it's historically thought of as older white men, but many populations of people can get Parkinson's disease, including women, including younger people. So it really affects the population worldwide, and it's a disease of what we call movement disorders, and affect other bodies.
Great, great. I just want to check with everyone out there. So I thought so. People are hearing an echo. Dr. Indu, do you have headphones maybe that you can put on and that might cut down and the echo? Because our guests are a loud echo when you speak.
Okay, is that better?
Can you get my stuff so it doesn't echo?
Yes, Deborah, we can hear you clearly.
Okay.
Okay, thank you. I'm sorry, Dr. Indu, what did you say?
Is it still echoing now?
No, much better.
Okay. I just turned the volume down on my computer. So
okay, perfect.
Yay.
Yay, great. I love it.
Do you want me to repeat the answer? Or
yeah, if you can repeat maybe what Parkinson's disease is so that everyone can definitely hear it, that'd be great.
Sure. So it's technically a motor disease that affects the nervous system that is in the category of neurodegenerative diseases. The cardinal motor symptoms of Parkinson's are things like stiffness, slowness, and tremor. Not everyone with Parkinson's has tremor. So there are like 10 to 15% of Parkinson's patients never have tremor at all. And it affects people's gait eventually in many populations. It also has a host of non-motor symptoms, things like sleep dysfunction, bowel and bladder symptoms. It can also affect an area of what we call mental health aspects. So things like apathy, anxiety, depression, sometimes cognition. All of these things are areas that can be affected by Parkinson's disease.
Great, thank you. And how do you get Parkinson's disease?
So that's a really good question. We don't actually have the answer to that. There seems to be some genetic predisposition along with a number of environmental risk factors. And I love sort of the holistic way that you approach and some of the social needs of health can impact the outcomes of our patients with Parkinson's. Certain types of toxins like pesticides and insecticides, certain types of other exposures, head injuries, certain things like that may predispose patients to getting Parkinson's at an increased risk. But we don't have all the answers as to why people get Parkinson's disease. There's still a lot of research to be done.
Wow, that is fascinating. So, Deborah, we know that you were diagnosed with Parkinson's disease. What were some of your symptoms that you had that led you to go to the doctor?
Well, early on, for almost 2 years before my diagnosis, I was having hallucinations. I was having these night terrors. I'd wake up screaming that someone was after me. I popped my husband in the head many times, terrorized. And I went to my primary, and she did all kind of referred me to sleep disorder, and even the therapist trying to figure out what was going on. And maybe 2 years in, she finally sent me to a neurologist. And in many ways, I say Parkinson's saved my life, because as the doctor, one of the things he recommended was that I get a MRI. I got an MRI of my brain, and guess what? He didn't discover if I had Parkinson at the time, but he discovered I had a brain aneurysm, that if it was not treated, it could burst at any time. But through that process, I did get the diagnosis that I also had Parkinson's. And as you shared earlier, a couple weeks later, it was time for my annual mammogram. And ladies, we got to have those mammograms. Even though I tried to talk myself out of it, I have Parkinson's and I have a brain aneurysm. I don't need a mammogram, but I did go have my mammogram, and was discovered that was cancer.
Wow.
That's how it began. That's how the journey began. And I just assumed I was going to die. I just assumed it was over.
Wow. Well, it wasn't, and you're still here today, and we are thankful for that. Dr. Indu, the signs that Deborah described, are those sort of the normal warning signs of Parkinson's, or what are some of the other type of warning signs that people might need to pay attention to?
Yeah, so classically, there's sort of this what we call a prodromal period of Parkinson's, where we might see things before the motor symptoms of Parkinson's. And these can be sometimes 10 to 15 years before we ever get the motor symptoms of Parkinson's. And when we see this constellation of symptoms in people, we may think that they're at an increased risk of getting Parkinson's disease. So one of the things that Deborah described was this what we call Rem Behavior Disorders. So Rem sleep, REM sleep, is when normally the mind is thinking a lot of things and sometimes in a dream state. And the body gets these signals in a normal person to sort of quiet the muscles from acting out the dreams. This quieting of signals gets disrupted in certain types of neurodegenerative diseases. And so we actually see patients yell out, sometimes act out the dreams as if they're fighting in the dreams or running away from somebody who's pursuing them. And so this type of problem can sometimes be seen by the bed partner. And we see, as we follow people with Rem behavior disorder, that they're at a higher risk of getting things like Parkinson's disease within a 5 to 10 year period after follow-up of those sort of symptoms. So it is something that we see before the diagnosis of Parkinson's disease in many populations. We also sometimes see a lack of sense of smell. So the sense of smell can change. We call that anosmia. And since smell is so linked with taste, sometimes our patients will describe a change in their taste, that their food was not as flavorful. Constipation is another thing that sometimes can predate Parkinson's disease motor symptoms by a number of years. Depression, anxiety, these sorts of things. So many of these things are relatively common, but especially the lack of sense of smell paired with that fighting in the dreams sort of is something that I think is something that we think can predict who might get Parkinson's disease.
Wow, the brain is so fascinating. When you think about that is just so fascinating, hearing about normally you're quiet in your sleep, you're not acting out your dreams, but that is actually can be a symptom of a more serious issue if you are finding that your body is moving and acting out while you're sleeping. So I hope you all heard that piece there. But some of the other symptoms that you also described, like anxiety or depression, all of those things are relatively common, particularly coming out of COVID. We're seeing an increased number of people who are depressed or who have anxiety issues. And so that probably contributes to why there's such a delay in diagnosis. Is that correct?
Yeah, I mean, I think also that in medical school, Donna, you might remember that we saw those pictures of that older white man who stooped over with motor symptoms. And there's this sort of this sense of who gets Parkinson's disease. But we see this in all populations across the world. We're seeing it in Africa, everywhere, in younger patients as well. So people in their 20s, 30s, 40s. It's more common as we age, but it's certainly not exclusively only in white older men. Women get it it is less common in women, but it's certainly very common in women as well. And in some populations, like Asian populations, sometimes it's equal that women get it as much as men. So we're probably missing this diagnosis in a lot of people. There's a lot of delay, and often, unfortunately, women, younger women especially, are getting sometimes years between when they have onset of symptoms. It takes them quite a long time to sometimes get in to see a doctor, in to see a neurologist. And I think that this is a very treatable disorder. Lots of lifestyle things that we can talk about if you'd like. And so we're really pushing to kind of increase the knowledge of the general public to understand that your sister, your mother, your cousin could have Parkinson's disease, with a constellation of motor and non-motor issues, and to help them get the care they need.
Okay, I think that's key. I want to just underline that for people, that really, if they're starting to have some of these symptoms, see their primary doctor, but you also want to try to push to get referred to a neurologist.
That's right.
Yeah. So Deborah, you shared that you went to your primary and you went to a sleep doctor and they finally referred you to a neurologist. When you went to see the neurologist, what types of treatments did they give to you to sort of help you to live with Parkinson's disease?
It really begins a journey. And, I think, first of all, I finally was referred to a neurologist who was great. And then I realized that I really needed to see a movement specialist, a neurologist who specialized in the movement as a movement disorder. So I did that. But, I think the first thing, Dr. Donna, that's just critical is that Parkinson's is not just a white disease. Black folks, Black people do get Parkinson's, and I'm a living example. I mean, the first thing we say that people say to me, I don't know anyone Black that has Parkinson's, but a lot of times they don't get the diagnosis because, as we know, we're dealing with multiple challenges, with high blood pressure, with diabetes. And one more thing is just, so I shake a little, that's okay. Mm-hmm. But what's critical is the best treatment, one of the best treatments for Parkinson's is that to delay the onset is exercising. And so the sooner you can get the treatment and the medication that can mitigate the tremors or things that would prevent you from exercising, the less chance of the suppression of the disease. So that's it. I'm one of my doctors because actually the examination is, you put your right hand out and you put your left hand out, and does it shake, and he has you do the walk, and so I call it the Harlem Walk, because he walk straight, and so I need to change it in a way that works for me and my culture and where I am, and so I. Because otherwise you go in and then they say you get this diagnosis, but the treatment really is educating yourself about the disease and exercising, and some of the things that Dr. Endo talked about are just critical to not curing it, but delaying or slowing up the progression of the disease.
Yes, that's great. And Deborah, you took my next question right out of my mouth, where Dr. Endo is that's talking about the treatment. Is the treatment to end the disease, or is the treatment to slow the progression of the disease, or is the treatment to just, kind of calm the symptoms? What are some of the treatments that we can give for someone who has Parkinson's?
Yes, we don't have a cure for Parkinson's disease. We're all searching for that. We've also been looking for things that are disease modifying. So I think that we have a sense that exercise is disease modifying. There's not really one pill that we can give that emulates sort of the exact effects that exercise can help. Additionally, I think from a lifestyle perspective, I've been very passionate about the effects of social connection, and staying sort of connected in your community and active in terms of the things you love to do. If you, sort of can keep doing those things, staying mentally active, staying physically active, staying spiritually active, staying socially connected with the people that love you, that's a huge part of, I think, the prescription that we think can really make a difference for how people live better with Parkinson's disease. And I think we have a lot of treatments that can help, especially the motor symptoms. So we have things that can change stiffness, can change slowness, we can change tremor. We have surgeries that are very effective for motor symptoms as well. But part and parcel of this, in my eyes, as sort of my background is in integrative medicine, is really sort of what people can choose who are living with this every day to live better and live more sort of holistically and thrive, and not just sort of pick a symptom and treat that, but really to sort of think about how they can really sort of pivot from a relatively negative diagnosis. But as you see, Deborah is doing a lot of activism, advocacy, really trying to empower other people and help them. So I think we have, many ways to sort of continue to engage. And really, I think, as has been mentioned, the first thing is, understanding about this, getting good resources, getting sort of on a plan every day to try to schedule things like exercise, social connection into your, day every day. If you don't schedule it, it's not going to happen. And then connecting with other people who may have it as well, and helping to sort of stay engaged in your community is very helpful.
That's great. And Deborah, in terms of the connection, you're connected to an organization called PD Active. Can you tell us what is that organization and what do they do?
It's really interesting. It's a great organization. I have to say first, because it's people who are living with Parkinson's. So it's an organization that became a nonprofit organization, and they run themselves and sort of identify the issues that they live with every day. So I think that's very special because we're so used to people sort of creating it, but they created it within. And as Dr. Endo supported, that social network is so important. These powerful support groups on Thursdays. The epidemic required us all to do things different. So it was interesting having, the meetings in person versus Zoom. But Zoom allowed people who are further progressed in their disease to be a part of it. Whereas if they had to go on site, a lot of them wouldn't be there. But just that social network and what works for people. So we talk about things like, how frequent do you take your medication? What works for you, around the, did you have the brain surgery? So sharing information, but also we were exercises. So there's yoga classes that you can, Zoom. I think they're eventually probably going to move back to some hybrid of it, but Tai Chi, meditation, every day of the week, there's something for us. There's young onset group. There's onset for those of us that have adults as children that may be our caregivers at some time, so that they can understand the disease now and what we're going through. Support group for our partners. And how I came to this table was they had these annual surveys, and a pretty large participation, and I emerged as one of the few self-identified applicants, and I was like, this is not okay. It's not okay to have over 1,000 on your list and not have a handful of people of color. And to their surprise, I have the respect for them. They're like, okay, we're here in California, East Bay, and it's not okay for us not to represent a broader range of people. So we came together and wrote a grant to the Fox Foundation that funded us to do outreach in target neighborhoods, which brought about, in fact, this event we're a part of with you, Dr. Donna, today. But it was like, how do you outreach to the American community and let them know that, yes, indeed, we need to be aware of it, along with all the other elements that seem to want to stick with us.
Wow, that's great. I love it. I love activism. Like that just makes me happy to hear your activism, and then being a part of the show today. Both of you being here, bringing awareness to the community so people can understand what it is and really get in early. So I want to go to some questions because there are some questions that have popped up while we've been chatting. So the first question is, probably for you, Dr. Indu, if you have had a prior brain injury or any scarring, does that at all increase your chances of getting Parkinson's disease?
Yes, I mean, I think the prototype of the person who has sort of what we call Parkinsonism, so, who looks like they have Parkinson's, stiffness, slowness, movement issues, tremor, is actually Muhammad Ali, who's done some amazing, work in advocacy and raising awareness. So, and his family continues the legacy, and I've met many of their family members, and just an amazing group. So people who've had multiple head injuries, like some boxers and stuff, certainly are at higher risk of having a number of neurodegenerative diseases that we see. Additionally, there's some new data coming out on even other head injuries. They used to say that you should have been adequately injured, that you might have passed out for a period of time or even ended up in the hospital to be at increased risk. So I think that's still sort of the party line, but we don't have all the information about exactly how bad the head injury needs to be for you to be at a risk for getting Parkinson's disease. Additionally, if you have scarring, sometimes people can have other neurological issues, that can look like Parkinson's disease. So it's still a clinical diagnosis. It's still something that you have to come in and be examined by a neurologist, and we put you through, as we were just speaking about with Deborah, a certain type of hand movements and open and close and tap, 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 watch you walk, feel your tone. So this is best done probably in person with, if you can, a movement disorder specialist like me, who spent 2 years subspecializing to know exactly what this looks like and what doesn't look like Parkinson's disease. Additionally, certain medications can actually masquerade, certain ones that we give for vomiting, for example, or even for psychosis for people who may have hallucinations or other, mental health issues. Sometimes the medication can actually block receptors and make people look like they have Parkinson's disease. So it is something that requires an extra set of eyes and an in-person exam. Definitely subspecialists have a higher likelihood to diagnose this accurately. And if you've had a bad head injury or scarring or an abnormal MRI, then it can be sometimes a little clouded what is causing what. So it's definitely helpful to get a specialist to weigh in on that. Sometimes we also give the medication for Parkinson's to see if the symptoms respond. If things do respond to the medicine, which the classic one is replacing dopamine, then we feel a little bit more comfortable as we follow people over time and get a sense of what's responding to what part of the picture may be from Parkinson's disease and dopamine sort of deficiency.
Great. So I hope you all heard that little nugget there that she kind of threw in, that it's a neurologist, yes, but you also want a neurologist that specializes in movement disorders. Both Dr. Indu and Deborah said that. So I hope you guys heard that. We want a movement disorders subspecialist from your neurologist to really help to make sure they're diagnosing the Parkinson's disease and helping to figure out exactly what your treatment is going to look like. All right, so let's see some other questions. I think you answered this, Dr. Indu, but I'll ask it again. Is Parkinson's disease an autoimmune disease?
We don't seem to think that it's specifically an autoimmune disease. There may be some inflammation, though. So the word inflammation gets sort of, used a lot. So there may be, inflammatory responses. Sometimes stress can contribute. There's a number of sort of changes in the cells that can look like these other sorts of problems. But it's not a classic immune issue where we give immune modulating things like medicines that block the immune system from sort of flaring up. Like in multiple sclerosis, for example, there's much more of an autoimmune sort of problem. Parkinson's is not classified exactly as that.
Great, thank you. What about deep brain stimulation?
So we have some really interesting technology. Some of this technology has been around for decades, actually, and historically, there was actually a brain surgeon who put a sort of a knife in the wrong place in a patient that was having tremor. This was in, I believe, the 40s or 50s, and found that the tremor got better and was like, oh, wow, we found a new circuit that generates tremor. So for a while, before we even had medications for Parkinson's, we actually had very sort of interesting surgeries where the surgeons would stick sort of ice pick like sort of objects into the brain and kill tissue. These sort of surgeries then got refined to more of burning or freezing tissue, and that was in the 90s. And then deep brain surgeries with electrodes being inserted sort of came about. And we still don't fully understand exactly how some of these surgeries work. Like the circuitry is very complex. But what we do know is that we've sort of perfected, I think, to many degrees, ways to treat tremor, ways to treat motor symptoms in people who are fluctuating. So when we give medicines for Parkinson's, sometimes we induce extra movement. You might have seen Michael J. Fox with those sort of writhing movements, the classic tremor that people get in Parkinson's. We can help with that sort of shaking. But the sort of other aspects of Parkinson's, which include non-motor issues that I mentioned, as well as sort of these mental health and cognitive issues, are often not changed by these surgeries. And so we still have to look and seek and treat other ways to help patients with these sort of other problems. But I think motor-wise, we're able to really help those extra movements and the tremors, stiffness, and slowness pretty robustly. This should be done in the hands of a team where you have a good neurologist who specializes in movement disorders, who's evaluating you, making sure that the diagnosis is correct, and that you've undergone adequate medication trials. So we're still trying to look for people who've had their medicines optimized by, a good movement disorder specialist if possible, to make sure that there's not some workaround, because it's still brain surgery. We're still sort of inserting electrodes into the brain with risk. We're implanting hardware, which can get infected. So these are obviously, and we're still not curing Parkinson's disease, even with these therapies. These are still symptomatic treatments. So, and then, a neurosurgeon, good training, and, a history of doing these surgeries. So if you're thinking about having this, you want to always ask, how many surgeries have you done? What are your own statistics in terms of outcomes, and get a good sense that the surgeon has experience, and take that time to do that.
That's awesome. Thank you, Dr. Indu. And if you have watched my show before, we had another surgeon on, Dr. Kim Rhodes, who said the exact same thing about when you're looking for a surgeon, ask those same questions. How often do you do this surgery? And really making sure that the person who's going to go in and operate on you, no matter what part of the body, is really someone who does it a lot. But I want to pull this slide up. There's a slide that talks about the motor symptoms and the non-motor symptom, so that people can actually see what we were talking about. It's a slide, picture of two women there. It's like a blue background, Donnell. And so just to really, yes, there it is. I don't know. But we will put this on this website as well. But I don't know if you can see it, Dr. Indu, to kind of go through some of the motor and non-motor and then the psychosocial symptoms.
Yeah, so this actually came from a paper that we just wrote that's pretty hot off the press. It was a paper that was included voices of women living with Parkinson's disease that are themselves healthcare providers. We ended up trying to really highlight gaps in care for women and sort of the sense of rebranding this disease. So we had an amazing medical illustrator who is the daughter of a Parkinson's patient who's based in Italy, a very international crew of co-authors, including a number of women who are healthcare providers living with Parkinson's disease, and we sort of highlighted a number of the issues that women specifically face more commonly than men in this paper. And so we had a number of motor symptoms. So women tend to have sometimes a little bit more tremor dominant sort of phenotype. They tend to have a little bit more anxiety and depression and things when they have some of the non-motor issues. Sometimes they have a very unique sort of set of psychosocial issues that can actually determine how they access the healthcare system. And I think that when I'm giving talks these days, I really try to emphasize the fact that we as women, and there's many women on this program right now, tend to sometimes put ourselves last. And we sort of are adopting the healthcare. We're providers for many people, right? We're the caregivers of our children, of our husbands, of our mother-in-laws, and we tend to put everybody else first, and we put ourselves last. And as Deborah was just saying, sometimes we don't get our mammograms, we don't go to the dentist to deal with our teeth cavities, and all of these things actually put ourselves, believe it or not, at increased risk of bad healthcare outcomes. And if we don't take care of ourselves, then it becomes much harder to take care of the people that we love. So if nothing else that anyone's listening to out there, we as women need to care for ourselves. And for Mother's Day, make a list of the things that you need to catch up on, be it the mammogram or, the checkups, and go get those done to just help yourself and put yourself first for once. We as women of color, or even people of color, also tend to really not take care of ourselves. So sometimes we see things that happen to us and I hope it goes away, or I'm too busy to deal with this right now. And we put it off and we put it off. And so what is seen in the statistics of Parkinson's disease is that women present later, and people of color, so Black bodies, Latinx bodies, all sorts of people that are equally at risk, or sometimes even possibly more at risk, tend to put off seeing doctors. They don't get referred to neurologists as much, and so they tend to often not get the care they need. And then when they do get treated, sometimes they are not good about taking the treatment for whatever reason. Sometimes women, even people of color, are offered advanced therapies like the one that we just talked about, deep brain surgery. And for whatever reason, they may not accept these therapies. Maybe they feel like it's too complicated, or they don't understand the risks, the benefits. We don't understand, but we are really not serving these populations very well. The other thing that I think is really important is that a lot of the data that we have when I give risks and benefit sort of conversations about medications, surgeries, a number of things, all of that data comes from largely white males that have been studied across the board for no matter what neurologic disease. So we need voices of people that look like us to step up and get the care they need, get participating in research studies, and really be voices that are talking about what is important to them. And so this paper that we highlight here really was one of the first times that women were able to come together and say, you know what, these are the 5 things that happened to me when I went to get a diagnosis. And this is what prevented me from getting that next step. And this is why I didn't feel comfortable. And so we're finally having these images being shown, and women across the globe connecting. And I think that is the silver lining of the pandemic, is getting together and feeling like we can hear each other and our voices, and then we can take that and then present it more confidently to the people that can help us get the care we need and advocate for us and really, help put ourselves first.
That's great. And I'm going to applaud you, because it is so true that people of color and women are often diagnosed last and later in almost all of our diseases. And so thank you for highlighting that and calling it out and reminding people that you have to put yourself first, ladies. You have to put yourself first if you are going to be able to care for your family. And you really need to make sure that you're okay before you can make sure anyone else is okay, right? Think about the airplane, right? They tell you put your oxygen mask on first, and then you put the oxygen mask on of someone else who might be around you. So let's take care of ourselves first. So let's see if there's any other last few questions here. Super women, yes, a lot of one. We're always super women. Remember to take care of ourselves. Can you speak to the side effects of the recommended medications? Are they significant side effects of the medications?
Shall I take that one? Yeah. So,
Yes.
so generally,
Yeah, you can answer Dr. Indu, and then Deborah, if you're on any medications and want to speak personally to that, please feel free.
I'd like to. So go ahead, Dr.
sure. So in general, the carbidopa-levodopa, or Sinemet is the brand name for this in this country, is actually very well tolerated. This is a medicine that we give to people. It doesn't matter what the age group is. I give it to the sickest of the sick patients, even in the ICU. So it is something that is well tolerated. It is important that it be given to you in the hands of somebody who knows how to titrate it, because it can sometimes drop blood pressure. It can sometimes make you nauseous a little bit. It's better taken away from protein to get absorbed so that we can see the effect. So there's a very standard way to titrate this, and generally it's very well tolerated. There are some medicines that we sometimes give in younger people. The dopamine agonists, for example, things like pramipexole or Inarol. These are medicines that actually have quite a number of side effects that may include things like impulse control issues. So sometimes people can gamble, sometimes seek pleasure-seeking behavior, become addicted to things like sex, and various other issues. So these should be really handled in the hands of somebody who knows what they're doing, along with somebody in the family member who can kind of report back, sort of how people are doing. There are still good medications, but a number of these things can affect other sorts of thinking processes and behavior. So it is really important that, again, we seek the care, that we're trying medicines in the hands of somebody who knows about this. And I really think that one of the important things for women, people of color, to come into doctors' offices with somebody who's going to be your cheerleader from day one. If you can find somebody that you trust, and I'm sorry, ladies, but it may not be your husband. It might be your sister, your sorority sister, your cousin, your neighbor, your best friend from high school. But you got to find that person, your daughter, and bring them into your appointments and have them write things down before you go to the appointment. Write down your list of questions, take your medicines in, take the other healthcare providers' names in. And if you can be seen in person for that first appointment, at the very least, you should, because that's where you're going to get paperwork handed to you that I can't give you over a Zoom screen, so that we can go over the paperwork before you leave. You know what the plan is. And then you go home and you try the pills as they were expected, and you have your sister or whoever that can hold your hand and make sure you're being consistent. And if you don't tolerate it, then you report back to the doctor why you didn't tolerate it. And then you work together with your sister and your doctor to figure out what the next step is. What happens is people don't know what they're supposed to do. They don't do it. They don't go back to the doctor because they feel kind of ashamed that they couldn't do it. And then we start again with a different doctor, or a year or two goes by. And so it's so important to get on that right treatment regimen from day one. And then, as I mentioned, some of these medications have side effects that need to be monitored by somebody else that you trust. So that sister, that, whoever it is, can check in with you weekly. Hey, how's it going? Are you still on it? Any problems with it? And they can write it down. Say, week 3, she had this problem, she started vomiting, and then we can, kind of take that next step.
No, that's great. And I talk a lot on this show about having your doctors be a part of what I call your dream team. And if they're on your dream team, then you should never be afraid to ask them a question, to pick up the phone, to call, and never be embarrassed about what you're asking. And they should never return your question with cynicism or talking down to you. And if they do, then that doc is not a part of your dream team, and they need to be benched. So we talk about that all the time. So thank you, Dr. Indu, for underlying that. Deborah, let's hear from you. You wanted to talk about what some of your experiences are with the medication.
Well, it's a couple things from the previous conversation. First of all, I just emphasize what you guys did, which is early detection is everything. And so we as a people have a tendency to say, if we don't give it a name, we don't have it. This is one of many diseases that the sooner we can get the diagnosis, the better we can treat it. So not frequently, but, sometimes I run into African Americans who are in wheelchairs or disabled by the disease. And I say, when were you diagnosed? And they may say, 6 months ago. And I often wonder if maybe they had the symptoms much earlier, but didn't get the treatment. And this is the end result. So, I encourage people, early detection is everything. Medication is similar to the disease itself. We all manifest it in different ways. And sometimes in the group, when I talk about the night terror experience I've had, people never experience night terror. It's more around the tremors. And so we each respond in different ways. We all think of, illness, that we all have similar symptoms. But what I've observed in group is we all react different or respond different in different ways. And the medication is the same thing. The copa, the cinnamon is a lifesaver for many of us, because it does allow us to continue a certain level of quality of life. But how you find the right combination is sometimes difficult. So some people may take a half a pill, some people may take a whole pill, some people may take a pill every 3 hours, others every 4 hours, some 1 or twice a day. So that's why it's really important to work with your healthcare provider around what works for you, and them give you space to try different things until you find the formula that works for you. But early detection is everything. And even if you don't give it a name, I had to come to the realization that it was here. What else am I going to do but deal with it?
Right. Well, thank you both for such an informative session and just so much information and knowledge. Thank you, Deborah, for coming on and sharing your personal experiences. And thank you, Dr. Indu, for being here with all of your professional experience. We really appreciate it. I'm going to give you a final word, a last little nugget, something you definitely want everyone to take away from this show. And Deborah, I'm going to start with you. What do you want people to know about Parkinson's disease?
That Black people do get Parkinson's, and that you are your best advocate. And so the relationship that you have with your primary, and I hope you have access to health, but if you're wondering what that tremor was, I had someone today that said, we've had 5 generations of women who identified that they'd had tremors, but never saw a medical person for it. And so, it's really important. And when one did go see the doctor, he said, "Oh, you just worked hard all your life, so that's what the tremors are about." Wow. But if you have the information, you know how to be your best advocate. And as Dr. Indu said, always have somebody with you, because you're dealing with it both at the emotional level, and then you have follow-up and action, and having that support is critical. Thank you.
Thank you. Dr. Indu?
Yeah, so 2 things. One is there is a stigma. So a lot of people don't come out and tell you that they have it, but many people are living with it and living normal lives and thriving. So it's really important to start the conversations. And once you start telling people and learning more about them and meeting people in your social circles, you'll realize how common this is and how treatable it is and how people are thriving right in your own backyard, as I'm sitting here in mine. But the second thing is that, customization of care is so key. And this is really, I think we're realizing that we need to meet people where they are. And so if you had a bad experience with a neurologist, or a doc that didn't listen to you, I think, keep searching for that person who's going to advocate for you. And it may not even be a doctor. It might be a physical therapist or a yoga teacher or somebody in your life that really takes that time and really connects with you and can kind of help you get sort of, the path. And once you feel heard and seen, I think then we can kind of work with you to sort of meet you where you are and customize, what works for you, both from a cultural perspective, from all the other medical issues that you're dealing with. And so it's not a one-stop shop. It's not a cookie cutter prescription that everybody gets, that has been sort of arrived at from studying white men. It's really about understanding who all in our world has this and really fighting to sort of make a difference so that we can help all patients with Parkinson's, across the world live and thrive better.
Thank you. I want to say thank you again to you, Dr. Indu, and to you, Miss Deborah, for being on our show tonight. I want to give a special thanks to Low Consulting Group, who helped to bring this event together. PD Active, thank you. And to Christine Harris, thank you so much for bringing all of us together and helping to make sure that this show occurred. So thank you to everyone. And to Dr. Indu and Miss Deborah, you're now a part of the Generational Health Network. So thank you for being here tonight. And I totally appreciate you. And I hope and I know that everyone out there is giving you applause and thanking you for your knowledge and for sharing with us tonight. So thank you so much. We're going to continue on with a little bit of our show, and you can come on in the backstage and keep watching, or I know it's late and you may need to go, but just know that we appreciate you. Thank you. All right, just a little bit more pieces of business. You know, every month we do a food of the month, and this month is no different. This is May. So we have already had multiple foods of the month, and this month we are our food of the month is one of my favorite foods. It's just, I could probably eat it every day, which is avocados. Yay! And it just so happens that today is Cinco de Mayo, and there's probably a whole bunch of you out there consuming Mexican food today in honor of the Mexican battle that won against the French. That is what Cinco de Mayo is celebrating. So if you're out celebrating Cinco de Mayo today and you're having guacamole, you are already participating in the food of the month with Talking with Dr. Donna. But why did we choose avocados? So avocados have a lot of health benefits. They are rich in healthy fats. So you probably remember there's good fats and bad fats. Well, avocados have healthy fats. They're also high in vitamins, so vitamin C, vitamin E, vitamin K, which is really important for your blood system and working well, vitamin B6, folate, which helps for if you're a woman who's attempting to be pregnant and have a healthy baby. Folate is very important. So they just have a wealth of nutrition in that little bitty thing with the seed in the middle. It also supports heart health, can lower your cholesterol, help to regulate your appetite because they are sort of a fat that when you eat them, it helps to kind of suppress your hunger, and it helps to keep your eyes healthy. So lots and lots of benefits of avocados. So many different ways in which you can eat them. So this month, I really want you all to participate in showing me some recipes and how you are eating your avocados. Are you putting it in a salad? Are you making guacamole? I put it on my tuna sandwich earlier today. Like I said, I could eat it all the time. So lots and lots of avocados. Let's see. Yes, Lotta1, I'm waiting for your recipe, Lotta1. I know you have a good one with avocados. All right, so that concludes our show tonight. Thank you so much again for keeping your appointment. As you know, you have an appointment every Thursday at 6:30 p.m. with the doctor, so don't miss it. If you have not already subscribed to my channel, I'd appreciate it. If you're not watching on YouTube, or if you're watching on YouTube, go right up there to that red bar where it says subscribe, hit that button, and then hit the bell icon right next to it so that you know every single time we go live. Thank you again for watching. Thank you again to our guests, Dr. Indu Subramanian, to Miss Deborah Whittle, to Low Consulting Group, to Christine Harris. Thank you so much. Thank you to each of you who continue to keep your appointment. Until then, we see each other next week. You take care of yourself. If you have a question for Dr. Donna,
please do leave it on my page and I will be happy to answer the question for you.